Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
Welcome, everyone. Welcome to another episode of the podcast. My name is Diana Ferreira. I'm a certified lifestyle medicine physician and a lecturer at the European School of Lifestyle Oncology. I'm also a cancer survivor. And today on the podcast, I'm very excited to welcome Kerry St. Pierre. Kerry St. Pierre is a licensed nutritionist and American College of Lifestyle Medicine diplomate. She holds 2 master's degrees in human nutrition and integrated health, both of which were completed summa cum laude. Congratulations. Kerry is the founding partner of an insurance-based private practice, The Nutrition Attaché. Kerry's specialties include nutrition and lifestyle interventions for cancer risk reduction and survivorship, and cardiometabolic conditions such as diabetes, cardiovascular disease, and obesity. Kerry serves as an adjunct professor at the University of Bridgeport, instructing students in their final semester of the Masters of Science degree program in human nutrition. Kerry holds a leadership role within the Lifestyle Medicine in Cancer Specialty Interest Group at the American College of Lifestyle Medicine. Additionally, Kerry holds the Certified Nutrition Specialist credential, the most advanced board certification for personalized nutrition practitioners. Prior to her nutrition career, Kerry worked as a finance professional for 15 years as an equity and derivatives trader at the New York City-based hedge funds. Welcome, Kerry. Such a pleasure to have you.
Thank you so much, Diane. It's so nice to meet you.
Let's start from the beginning. I would love to hear how your interest in lifestyle medicine developed, and especially your interest in lifestyle medicine in the context of oncology or to support cancer patients and survivors.
Yeah, so we were talking a little bit before we started about how much we both love our being an ACLM board certified diplomat. My interest in lifestyle medicine developed shortly after I launched my clinical practice and started working with nutrition clients, nutrition patients, because it felt like is that everyone was coming in for nutritional counseling, but they were also tapping in to these other topics on sleep, stress, exercise, and how those pillars of health relate to the nutritional counseling that they were receiving. And so it felt like it was this lifestyle medicine model, the 6-pillar framework model, was highly applicable to nearly every encounter that I was having initially. And, irrespective of whether they were coming to see me for help with a GI, a functional GI condition, or something cardiometabolic focused, or risk reduction and survivorship, it felt like every session, there was always this conversation about sleep, exercise, avoidance of risky substances. And so I looked at many different certifications really that were more siloed in each pillar. And that felt too deep. It felt too deep because it wasn't like I was going to hang up another shingle. I wanted to remain a nutrition professional running a nutrition practice, but I wanted to be literate enough to speak, intelligently and through an evidence-based, leveraging an evidence-based model to have these conversations about like what can I do, and then when should I refer, and then who also should I partner with in an interdisciplinary, if we're really thinking about if your practice really wants to be interdisciplinary and have this referral network. And so I found the ACLM, and it was that was kind of it. So I presented for the 2022 boards, And, um, I don't know if on the channel you've talked about kind of like what the the timeline is like and how that.
No, not at all. Go ahead. So we're just for listeners, we are both certified in lifestyle medicine. And so we have lots of things in common and we go through this process to be certified. So go ahead and speak to that because I think it's really interesting.
Yeah, so you basically take a board review course. Um, I think it was like about it took me about 3 months, was it 3 or 4 months? Something on that order. Um, I put out feelers to create a study group, and,
Right.
we had I did not know what I was getting into. So there was a very big response.
Yeah.
There was 50 of us, the 40 or 50 of us that would meet over the course of that board review period. Um, and then we all presented for the exam. So I think it was like really like, I want to say like a 6-month process, something on that order.
Yeah, I think so. Yeah.
Yeah. And yeah. So then a lot of us, it was really wonderful. The people who responded to this study group call were from all different levels of their career. Um, you have to be master's level or higher. So it's primarily a physician-led organization itself. ACLM is primarily physician-led. So the majority of the representation was DOMD. And then I would say, then a mix of NPPA, RD, CNS. So it was really nice to have different specialties within even our own little group that we put together for the board certification. And I turned it into a mastermind group after that.
Yeah, which is amazing. So I didn't even, well, I was based in Australia back then, so I wasn't probably aware of everything that was happening at the US at that stage. But yeah, such an interesting concept that you had a group to study with and different professionals to connect with. So brilliant. So I was wondering if we could speak a little bit because you are, of course, we're going to base this conversation in nutrition, but like you said, there's a real connection with all the other lifestyle pillars. So let's perhaps start with that and just state them and just enumerate the lifestyle pillars and what they are, which is basically nutrition, um, physical activity, uh, toxic exposure or the absence of toxic exposure, sleep, relationships, and what am I missing? Stress management, and I think it's all. Am I missing something? Yeah.
Nutrition, exercise, sleep, stress management, social connection, and avoidance of risky substances. So, yep. So in ACLM, we have various member interest groups or specialty interest groups, and as you mentioned, there is one for lifestyle medicine and cancer. So that we feel, although we feel yes, we have to discuss all of these pillars, we've really focused, I think, them for the most part on where the evidence lies. So there is a very high level of evidence for 2 of those 6 pillars. And it's not that we don't address sleep or risky substances or social connection. It's just that when we look at, how I explain to patients and clients is like, if we printed out everything from PubMed that we have and we stacked it all up, some of those pillars, we'd have a stack that's, this high. I'm making a hand gesture if you're only listening. Of about 18 inches. And then some of the pillars, we only have a stack of evidence that's about 3 or 4 centimeters. It doesn't mean that what's in that 3 or 4 centimeters of research should not be considered. It's just that if we're looking to really leverage what's out there currently, we would probably be best suited to at least evaluate the ones with the deepest piles, the highest, the tallest piles first, and then also have discussions about those other pillars more through the lens of how do they enhance your quality of life, not necessarily change or shift or impact a cancer diagnosis outcome or a risk reduction or cancer incidence profile. So that's kind of how we think about all of the pillars. And then nutrition specifically, you know, in the ACLM's official, position on nutrition, it's very parallel to what the ACLM's broader position on diet. It's very similar, parallel to what it is in LM in cancer nutrition. A whole food, plant predominant, plant predominant diet that offers benefits for prevention and can aid in the care of conventional treatment. So being very clear that this is not a substitute for treatment. This is adjunctive. And again, coming back to this idea that the proper diet during or after cancer treatment can also really substantially create improvements in the quality of a patient's life.
Yes. Yeah. Which I mean, it makes perfect sense, and it also makes perfect sense to have some focus on cancer in particular. I don't know if you feel that in clinical practice, and I'm going to ask you why the particular interest on cancer and cancer survivors. Um, but I certainly find that, or in my experience, it's a population that it's very um, keen to make lifestyle changes, and they search for evidence in nutrition and what they can do to sort of improve their bodies during treatment. So I find them actually quite receptive to these changes. So I would love your perspective on that, but also to know why your particular interest in cancer.
Yeah, how I started to shift more towards working in risk reduction and survivorship. When I first launched my practice, the majority of the cases, the majority of the people that were coming in were really more cardiometabolic focused and the more typical lifestyle diseases, cardiovascular disease, diabetes, weight management. And within that group, I would say that probably half of them had a family history of cancer that they were also talking about in sessions. Oh, my father had prostate cancer, my mom died of breast cancer, and they were talking about these fears. I'm here because I don't want that to happen to me too, because as a child or as an adolescent, I lived through that. And I want to release weight or I want to improve my cardiometabolic profile because I don't want to repeat that fate. So really, even though I was seeing a lot of people primarily for diabetes or, like I said, weight management, they were talking about risk reduction. And they didn't identify it specifically in those words as risk reduction. And I felt like I was getting more and more moving up the curve as well, sort of like independently, is this something that I do? Do I become like a risk reduction nutritionist? Is that even a thing? So, um, I tried my best to get sort of self-educated in a way, in a professional and academic way. But it really wasn't until I joined ACLM and realized that there's this whole pool of knowledge that's right there that I can access, in our member interest library. It's all of the professionals. It's the entire range of healthcare professionals also exists within our cancer MIG. So you get to have conversations. There's resources, there's patient, there's provider facing resources. There's this beautiful toolkit that was published a year and a half ago, that is primarily provider facing, but there are patient, handouts that are there as well that can help assess readiness. In that patient facing side, there's a framework of dip, wade, what do we call it? Dip, wade, dunk, dip, and essentially creating this dip, wade, dive, excuse me, dunk. Sorry. um, Dip, wade, dive, which essentially is trying to gauge readiness in terms of like a behavior change model. And so I was like, wow, this is amazing. I feel very well as a clinician. I feel very well supported now that I'm starting to have these conversations and leveraging, like I said, this wisdom from this very deep pool of knowledge. Sammy Mansfield is my co-chair over in that MIG, in the cancer MIG at ACLM, and she's a 20-year exercise oncology professional. So even if my sessions only involve a 5 or 10 minute conversation about exercise and survivorship, I know that I'm giving them the highest quality of information because that is coming from someone who is a co-author of the ASCO exercise guidelines. Nigel Brockton is our other chair. He's a PhD. He's been doing cancer research for 20 years. He's the VP of research at AICR. So he's he's incredibly accessible, and he's really funny. I think academic medicine can be very intimidating. Right. But he is, definitely he'll correct you if you have a preposition wrong when you're stating something of the evidence, which I appreciate.
Yeah.
But if I really want to be 100% certain about how I'm distilling the evidence in a way that I can present it to a survivor or to someone coming in for risk reduction, I am so sure that the source is is impeccable. These are really unbelievably talented people, and we have this brain trust over there. And so that's really when I started to feel this like confidence, like I can do this more. I can really feel like I'm giving the best advice, but I also have to remember that this is patient-centered care. This is personalized care, and this is very different than working with someone who's coming in for diabetes, weight management, or IBS. I had a wave of IBS people come in towards the end of this year because things got really spicy over here in America, and I had this just like it was like everybody was coming in for IBS. But it is I think as a clinician, I kind of like and practice owner, I took a step back and was like, I had to really reflect on what do I need to know about everyone who's coming in here? What is what are the complexities and intricacies that are involved with delivering this beautiful pool of information? I have it. Check, check, check. But what do I really need to sharpen as a clinician? What skills do I really need to sharpen as a clinician?
Yeah. Which is, I mean, what you're talking about is basically a multidisciplinary team that is there to support you I mean, you all support each other, which is really beautiful in terms of patient-centered care. Absolutely. And you touched on so many interesting things, but it comes to my mind the coaching aspect as well, because in behavior change, I mean, you can have lots of information, but if you don't have the skills to sort of select and work with your patients to uh, I wouldn't say only encourage behavior change, but propose things that they will be able to do and they are willing to do. And I think that's a really key and interesting aspect as well. So having a team for that is sounds beautiful. So yeah, thank you so much for that. And what else in terms of the group and the output of work? by the group. So I understood you're sort of a team. In terms of the output and how regular clinicians can access these outputs, do you have any advice on that?
Yeah. So you don't have to go through the board certification like we both did, which is a lengthy process. And it's really, that's after you're really committed to really wanting to use this, I think, in clinical practice or in some professional manner. That's one option for what we're talking about as far as, lifestyle medicine implementation. You can also become a member of ACLM, where I think it's pretty reasonable. There's different tiers of membership. I think, and it drives off of your education level. So let's say I'm dual masters, so I think it's $150 a year, something on that order. DOMD, sorry, you guys, you have to pay a little bit more.
Right.
I think I still think it's pretty reasonable. I think it's about $200, something like that. And then you can have access to this entire conversation that's going on within the specialty group, the member interest group, the cancer for, lifestyle medicine and cancer group, where, all of us are there. And like I said, I think we're up to 1,100 members right now. um, I undertook a project to create more of a networking database. And as I'm harvesting information from our members, we're at about like 200 or so. So 200 of those 1,000 have decided that they want to participate in our membership database. Um, it's stratified. I asked them, what is your professional distinction, and how are you, what capacity are you working in, or what is your work setting right now? And it is primarily people working, uh, directly at the hospital. They're hospitalists, they're hemonc, they're radiologists. So it is MD, DO, and then an APRN and MP. So you can, like I said, that's who you're networking with. That's who you're interfacing with. I focus on the nutrition content. So if you go, my contributions to the library, we have in the library, we have any piece of research that is related to lifestyle medicine and cancer. We want to make it like Sammy calls it the hall closet for your research on LM and cancer. You can just be very sure that it's always there. And then we'll have conversations about that, whatever piece, whether it's some trial data or some observational data. The conversation will flow around there, around those selections that are put into the library. And of course, it's free form. You can ask whatever question you want. The nutrition questions that come in, anything from was trying to support a patient who has anemia and fatigue, and we can't seem to figure out, post treatment, like why this is not resolving. What are the options? Something like that. Um, and then we host topics. We host webinars and workshops on topics. We did one yesterday. We had a woman who really has focused her research on alcohol. Uncorking the Evidence is the name of our webinar. And, really going through at a pretty detailed level what has been published in the state of alcohol and the relationship between alcohol and cancer. Is there a safe dose? Spoiler alert, no.
Yeah, exactly.
Easy. And where that myth came from. Why does everybody believe that? Why does everybody believe that 2 glasses of wine is safe? And so if we really assess the evidence, is it low risk? How do we stratify the risk? Is it no risk? No risk is 0. Low risk is 1 to 2 glasses. So that was our webinar we did yesterday. And then Nigel, about a month ago, did a very lengthy webinar for us on going through every pillar and the research that in publication on every single pillar. So we made a stop We did have well, the lion's share was more on diet and physical activity. Um, I think if you look at AICR,
Right.
if the research, if that's a resource that the audience hasn't gotten familiar with and they're interested in those two pillars, AICR, fabulous, fantastic patient and provider facing handouts. I think in many ways, when I look at their website, I think I would love I take a lot of cues from what they've developed over there because I think in terms of implementation, what they have over there is something that we really can try to replicate within our cancer MIG at ACLM. So,
So yeah, lots of different resources and we can put some of them in the notes show so people have access to it. Absolutely. So let's dive in nutrition because I know there's lots of evidence in nutrition. It's probably one of the hot topics in cancer in general when we talk about lifestyle. Um, it's probably too broad of a question, but what's the role of that pillar, Kerry, and the evidence we have regarding nutrition up until now? And I know there's lots of phases in the cancer journey that we can then sort of tease out in the conversation. But how do you see this pillar related to all the other pillars?
right. Yeah, that's a great question. So I think so we really focus in the cancer MIG and in my own practice, I focus on two distinct points in the cancer continuum, the risk reduction and survivorship. And so as it relates to survivorship, I think we publish a bit more and we talk a bit more, and what I see in my practice a bit more is on the survivorship side. The risk reduction side, the people that I see that are coming in are more like the daughter, the son, with advanced genetic and genomic screening. I'll have people coming in oh, I have Hal B. You're like, okay, so trying to educate them, what do we know specifically about when we're working with somebody with one of these gene variants and their mom had breast cancer.
Right.
So,
Yeah.
um, so how do they relate to one another? I guess I'll go with that question first. So ACLM, I do think honors across all the specialties, whether it's, an endocrinology focused or sleep focused, there is a foundational relationship between all of the pillars and nutrition. And I think, and I'm trying not to, see the world as a nail and on the hammer, but, but I do think that it's very hard to get improvements in sleep when the nutrition piece is extraordinarily, I'll just say dysregulated, or if the diet quality is extraordinarily low, the eating rhythm is extremely incorrect for how the person is living. And I think in lifestyle medicine and cancer, also we do tend to think that whether we're at the survivorship point in the continuum or the risk reduction, we do know that this is an incredibly valuable, high impact place to put your attention, to put a patient's attention. Is it going to guarantee an outcome? No. We have to be very careful about um, blaming people, who come in. I will say that I have survivors who come in and express all this regret because they didn't live a certain way, and that's why they got cancer, or they're addled with fear because they feel like they were engaging in XYZ behavior, and that is the causal relationship between the diagnosis and their behavior. And so I do feel like we have to be, yes, it is extremely valuable, but it might not account for every reason someone has cancer. And it might not be um, this 100% do everything perfectly. That puts a lot of pressure on people. if you try to say be perfect,
Right. Yeah.
that's unfortunately a lot of the messaging that's out there is that have to be instead of progress, instead of perfection, we want progress. Yeah.
But
Progress over perfection. I think that depressurizes a lot of the engagement as well and puts them in a place where a behavior change becomes more accessible. And again, we haven't really even accounted for some of the specific emotional stuff that's going on when a cancer survivor comes in, or even someone who comes in for risk reduction. You really have to listen to their whole story. Why are they here for risk reduction, nutrition, and lifestyle? Was it because they saw a parent get sick, you know, and they don't want to do that? So they're operating from this place of fear. That's a lot of tension and anxiety to hold in the body and then try to create behavior change. I hate using fear as a motivator for behavior change. I do not like it at all. I think that we get so much better outcomes when we, like I said, I use the word depressurize. Let's let's talk about the pile of evidence that's out there. Let's talk about the 18-inch research stack. How does this apply to you? It doesn't matter how it applies to Joey or Francis or whomever. How does this apply to you? And how does it apply to your story? So yes, it's like I don't want to sound like I'm talking out of both sides of my mouth to someone. It matters, but it doesn't. No, no, no. It matters, but how we cast our gaze, like how we chart our course is going to be deeply, deeply individualized. And it's going to be very different than somebody coming in, like I said, for diabetes. There's just like a whole different set of factors.
yeah. Thank you so much, Kerry. And thank you so much for highlighting that because I don't know if you see that in your context, but for sure we see um, many people in our context making changes out of fear. And I guess the beauty of this type of approach is exactly that you understand that um, this is not only about nutrition, even though you might want to change nutrition. The motivating factors behind someone's choice to approach that, it can be very different, and it has a real impact on people and in outcomes. I think so. And still, I see lots of health professionals trying to motivate people to change, trying to sort of instill some fear as well. So if you don't change, you'll be sick. Or and I don't know if you see that a lot, but I do. And I think if you don't have some sort of understanding of the other pillars, and including, for example, the relevance of stress in your body, you wouldn't be um, yeah, I think you need to have that in account and not only try to impose some changes just for the sake of imposing some changes that we think uh, they might be good for patients.
Right, right. And I think the question you asked before about what, what is it, what is the encounter look like, or asking you sort of what is the initial sort of engagement look like. I'm hyper aware of food anxiety that people are coming in with, because the food anxiety can create hypervigilance, and that's really not what we want either. So we don't want, if someone comes in and you give them this open space, tell me about your relationship with. I don't start with tell me about your relationship with your body. That's that's a question. Yeah. But tell me about your relationship with food. Tell me about what role food has played in your life. Let's say this is a survivor prior to treatment. And then tell me about how you envision your relationship with food from this moment on, going forward. And it's interesting. I would say that the majority of the survivors I work with, they are not in hyper vigilance mode. They are not in no sugar, no processed food, whatever, Instagram-y, TikTok-y thing that they've consumed. They're really not that's not the majority of the people that I have seen. Keeping in mind, I work in an insurance model. That's how I express my commitment to health equity, because really there's just not everyone who has gone through treatment has the financial capacity to afford private nutrition care. So I feel like I run a very equitable, I take if I am on as many insurance panels as I I could get myself onto. Um, so I don't see tons of people coming in with these extraordinarily limiting, hypervigilant beliefs. What I do see a lot of is pretty, um, I wouldn't say this directly to a survivor, but the diet quality itself generally is pretty low. And that may be, and this is where we have to be super careful. And I think this is where in the cancer MIG, we're really trying to work on this too, is how do we make LM for cancer very specific to the needs of the survivors. I I want when that conversation is happening about a low quality diet, we don't use that word low. We say this is a diet that is deplete in certain nutrients and there's room for improvement. Or this is a diet that is lower in fiber. And then we talk about, point the laser at maybe increasing fiber, because if we do that, then likely that means that, right, where's fiber come from? Well, it only comes from plants, right? So how do we
Right.
point the laser at fiber? Then we know we're achieving that outcome, or we're gliding towards that plant predominant framework that we really want to work in. But I think that, you know, what's important too is we never wanna embarrass or assume that the reason why the quality of the diet is low is because they are just, like, lazy or they don't want to, or it may really be because they've had significant, I'll use a few clinical words. It may be because they've had a few, major changes in dentition, or they might have dysphagia. They might have had radiation that caused all of these swallowing and chewing issues. Maybe their digestive capacity or too much fiber has been impacted by treatment. So I think that's where I really, as a as a member of the Cancer MIG and part of the executive team want to focus is like I just want to just be very sure that yes, we're advancing the plant predominant narrative, but we're also making an enormous amount of, I don't want to say concessions, but it's considerations for things that may be going on that we take for granted that these patients are coming in with like that they don't have taste changes, that they don't have smell changes, that they don't have mouth sores, that they don't have dry mouth. I think that's really critical that we spend more time talking specifically about that kind of implementation. We're doing a lot of implementation work over there. Um, this one is important. How do we address those common post-treatment side effects that are directly affecting intake, especially the intake that we're talking about, which is the diet quality shifts towards more plants?
Right. Yeah, super, super important in the cancer realm, and for sure something that we not always consider, and that has a real impact on people. And I think would love your perspective on that as well. But and drawing on my personal experience with cancer, but I really feel that as a cancer patient, there's lots of moments so the body is not it's not often when while you're going through treatment as a source of pleasure, and then food, I think it might be one of the few pleasures we have in life, at a certain stage. And I would love your perspective on that, the role of pleasure through food for a cancer survivor, or even in someone who is just in the prevention stage.
Yeah, I think that really relates to the conversation that I do have when I do have people who come in with this hypervigilance. I do talk about what joys of eating do you miss? Because they're eating in a very, very restrictive framework, so in terms of, like, how many foods are in their food portfolio, to use a, more nutrition-focused term, the food portfolio went
Yeah.
from being abundant, or even if in risk reduction, it went from this abundance of foods, including these foods that are sort of like the joie de vivre, the chocolates or grandma's famous cheesecake, and then they move into this place where they're so terrified that one bite is going to really either promote the growth of cancer or promote the regrowth of cancer. And when those are hard conversations. Now we're kind of moving back into the psychology of eating, and I think there are some really incredible um intuitive eating specialists who have talked a lot more about this, and I draw my wisdom from the body image world and the intuitive eating world when I have to have these conversations with people who are really addled with fear. And the way I guide them, if I've identified that this is they're in a very restrictive pattern, I can use a lot of logic. I can show them again the 17-inch stack of research. It doesn't go anywhere. But if I do exercises, like I ask them to just kind of like soften their gaze and think about their dietary pattern versus thinking about one individual bite that they're putting in their body, because it has never, ever been demonstrated that one single bite of cheesecake or one piece of cheesecake, it's always cheesecake. I feel like I always use cheese.
I feel this is a very American thing.
Is that?
For us, it's something else like pudding or something.
Um, so I asked them to really soften their gaze and describe, before they were eating in this restrictive pattern, what did it look like? Like, take your bifocals off, take your glasses off, take a step back and describe to me what food looked like. And then all of a sudden, you hear them engaging and talking about, like, oh, when it was Easter time, I used to eat the Cadbury cream eggs. Okay, cool. Cool, Cadbury cream eggs. That's awesome. When it was the holidays, whether it was Passover or excuse me, Rosh Hashanah or New Year's Eve or 4th of July barbecue. Sorry, I'm trying to be less American. Darn it.
No, that's okay. That's perfectly fine.
Um, what did that look like for you? And then how did you feel? And then we stop and then I talk about, how did you feel? How did you feel? How did it feel being social? And then I do talk about, that's really when I bring in the social pillar. If there's an entryway to the social pillar for what I do, it's the role that nutrition plays in sharing bread, sharing a meal, participating in the creation of a meal where let's say you're the one with you are a survivor, but you're also have another medical diet. Let's say you're a survivor and you're a celiac. How does
Right.
that feel to bring the gluten-free salad that everyone got to share and give you a compliment on? So I start to, again, it's like there's less of that stack of research logic work, and there's more of these feelings. Let's talk about, okay, I'm gonna go for it here, Great Britain. The Yorkshire pudding on Christmas Day. Did I get it?
No, but we have other like egg pudding and like special cakes. We have lots of different things. So, but yeah, go ahead.
Gotta stay in my lane. I should have gone with Italian pastries. I know those pretty well. So the joy, bringing the joy back into eating. And I do think, again, that there has to be, first and foremost, we have to address the anxiety and the fears that are underlying this these behaviors and where is this information coming from? This is unfortunately, yes, we are in the information age, but that doesn't tell us anything about the quality.
Yeah, absolutely. Yes, and I would love your perspective on that actually, because so two things come to my mind. I would love you to clarify what plant-based means, because for some people they hear vegan or vegetarian, or so would love for you to clarify that. And then I would love your a view as well on this information age where you look online and you see the best diet for you is carnivore. Now it's very fashionable. Or the best diet for you is plant-based, or the best diet for you is, I don't know, something else, ketogenic or something like that. So how can a cancer survivor sort of navigate all these different, which is like an overload of information, and some information is valid, some is not. But how can we start navigating all these different opinions? And also when you look online, it seems there's evidence for everything. So I would love your views on this.
Is a really great question. So I think for a for a patient who is looking for a patient or a provider who is looking for a very concise one-pager framework that outlines what is the what how do we use nutrition as part of a survivorship plan.
Right.
AICR has a one-pager that outlines the framework that is very, very much aligned with ACLM's dietary pattern statement. And so I can probably link that in the notes. And that,
Right.
effectively, it is a plant predominant. What AICR, they will use the term plant-based when they're talking about plate construction. And they'll say, take your plate, 2/3 of your plate plant-based, plant predominant. Whereas ACLM will be saying your whole plate should be plant predominant. And then through the week, meaning through your rest of your dietary pattern, there is an opportunity to have uh, eggs or other animal proteins in there. But the focus is really on that ACLM plate graphic, which is a plant predominant plate. But I think what AICR does really well is when they created their handout, and we're trying to replicate this, we're redoing some of our handouts now. Um, I think what they really do an excellent job of is, with their plate construction exercise being 2/3 plant forward foods, plant predominant foods, vegetables, whole grains, beans, fruits. The other third, there's more flexibility. There's a little more flexibility in terms of the lean protein, so the fish, the poultry, the eggs, or the tofu. And so, they give specific guidelines about how frequently you should be including red meat and, completely minimizing or eliminating your exposure to uh, processed meats, hot dogs, sausages, bacon,
Right.
So I will say on the topic of hot dogs, that is another embattled ingredient. And then I'm not saying that everyone should eat hot dogs, but it seems to be the one question I get a lot, specific food type question I get.
Right.
Is it true that if every hot dog I eat, I lose a minute of my life? And I'm like, that's ultra precise. That's ultra precise. And I explain the research methodology that was behind the study that published, or that soundbite that came out of
Right.
that data set. Um, so I think that like I said, if someone was a patient or a provider was looking for one handout, I would go on nutrition and cancer as a part of your cancer treatment plan. That I would go to the AICR's site right now and download that one. It's excellent. And it's very clear about how nutrition can help you. in terms of the quality of life, helping you recover a bit faster, supporting your immune system, helping you tolerate the side effects of treatment. So I think that's a great job. As far as the accepted definition, what is vegan? What is vegetarian? What is plant forward? What is plant predominant? What is plant based? Um, the ACLM prefers plant predominant. So that means that it is as what we would consider more casually, I think, an unprocessed food, a whole that grew out of the ground and went through a minimal amount of, when in session, I'll use more like common words like tinkering. Right. Perhaps it was dried, perhaps it was washed, perhaps it was peeled, but that's a minimal amount of tinkering. Because I do feel like if if I start going to like ANOVA classifications and things like that, those are tools of research. Those are things that when academics, scientists, graduate students write papers, that's what they're using. That's not really going to come into the session. You want to like I keep it very, very straightforward. How much has this been tinkered with before it's going into your body? And we want to, think about again, not does it, what happens if I have a potato chip? Do I self-destruct? No, you're not going to self-destruct if you have a potato chip.
Right.
We have to, again, coming back to that exercise, let's soften the gaze. Let's think about the whole week. Let's think about the whole month. Let's think about the whole 6 months. Let's think about the whole year. I don't want to know what you did on your birthday. The only rules are on your birthday that you don't eat anything that's spoiled or you're allergic to. You should eat the cake. You should enjoy it. Depressurizing things. I think that got both of your questions. The plant predominant.
Oh, yes, absolutely.
So what is the actual definition? So we stick with ACLM 6 with plant predominant. Um, Vegan is very different. Vegan is very. I do have people who come survivors and people interested in risk reduction come in. The other framework they come in, the two frameworks they come in looking for, because they want to implement it or they want education about it, are vegan or ketogenic. And I'm dealing like, could we barbell more, right? so, um, I if they want a ketogenic diet, I do refer them out. I have colleagues who specialize in therapeutic ketogenic diets, and these are colleagues who have been doing it for epilepsy for a dozen years, 2 decades, and now they're doing it more as it's being studied in an inpatient setting. Actually, it's really interesting for GBL. Um, so I will refer them out. I don't ever recommend the carnivore diet for anything to anyone under any circumstances. I do educate people, though, that I think that people feel therapeutic benefits with the carnivore diet because they had some sort of functional gastrointestinal disorder where their body was unable to deal with, perhaps it was the carbohydrates, because that's really what's primarily coming out. And so I think that, I do education about the carnivore diet, but never any implementation. Uh, and then, in terms of plant-based, plant predominant, plant forward, they get used interchangeably. In the research, it shifts around. I don't know. It shifts around which each one of those precisely means. But I center my language around the ACLM dietary position statements and what we're doing within the ACLM cancer MIG, which really does piggyback off of some of that AICR content that's already out there. That is highly evidence based.
Well, thank you, because I think this is such a big issue with cancer survivors, and just coming in and asking, do I need to go vegan? Do I need to go, plant based? Do I need what do I need to do? So it's I think it's a very important conversation. We talked about some ways in which the nutrition can sort of be taken out of context in these fields. Is there anything else that you would like to add about that? How nutrition is taken out of context in a in a in a treatment plan or by patients, by health care professionals?
Right. Yeah, I think that it toggles back into what we were speaking about earlier, where things are not being applied in a patient-centered way. They're being applied at the population level way, which is, again, it's not accounting for an extremely important set of variables or assessments. So we talked a little bit about, you know, fear, the impact of anxiety, um, the readiness of behavior change. And I think what unfortunately can happen is that clinicians are not recognizing or honoring that the person sitting in front of you, just because they've been given the all clear, just because there's no evidence of disease, it doesn't necessarily mean that they're ready for even the nutrition beyond very basic nutrition education as it relates to cancer. And you're doing them excellent favor by putting the education in front of them and doing an assessment on how ready they are within the next 3 or 6 months to do some implementation. And so I think when it gets taken out of context is that we're trying to take these very big, important cancer prevention guidelines, right? Because cancer prevention is different than risk reduction. Risk reduction is the individual level, and prevention is at the, you know, at the more population or global or countrywide level. Um, and we're trying to just kind of put them on a piece of paper and say, oh, you know, this is what we know, and here you go, and here's the handout, and now head off. And so I think we have to be really careful in LM broadly speaking. I think I haven't encountered much of this within the ACLM peers, but I do feel like I see this in cancer influencing. I could I will tell you, I will be completely honest, I kind of stay off the internet.
I think that's great sometimes.
Um, you know, it's it's too hard, too fast. It's not accounting for values. It's not accounting for fears. It's not accounting for um it's not accounting for essentially for readiness.
Right.
We have to make a decision. We have to make a determination as providers when we've brought this education in front of someone. Is this empowering or is this producing more anxiety? And I will pause in my session and ask people, how does this feel? How did this feel when I shared this um, fact about soy and breast cancer? If I have somebody and those the soy rumors and die hard. They are out there in an enormously high volume, and they're very scary for a breast cancer survivor. So when I educate very sensitively, very thoughtfully, very deliberately about the fact that this has been debunked and debunked roundly, and that we actually think, soy, whole soy, tofu, tempeh, edamame can be a wonderful source of protein for breast cancer survivors. When I gauge the person's reaction, I'm being really sensitive. Like, I just gave them a piece of information that may have shocked them to the point where they kind of froze a little. Like, how is this nutrition lady telling me what I know to be true because I was educated on the internet? And I never want to embarrass anyone. I never want to, you know, oh my God, you're getting your content from XYZ influencer. You never ever have to be so sensitive not to do that. And I touch base with them, how did that feel like getting this newer or updated piece of knowledge that we can incorporate? And I would say broadly, it's positive. They're appreciative. Thank you for clearing that up for me, because that's the part where that's what I want to see. I want to see the signs of empowerment, that the education was empowering, not anxiety provoking. And if I hit something that feels anxiety provoking, I back off. And it could be related to body body weight. In
Right.
the research, in the research, the term is body fatness a lot, and
Right.
that could be extraordinarily triggering. That could be
Right.
extremely triggering. Um, my conversations about body image are extraordinarily gentle, and I give people, and this men and women, when I have a prostate cancer survivor or a colorectal cancer survivor man come in, Um, if they are willing to open up and talk about how this has affected their body image, I let them talk, because all of
Right.
this is related. All of it
Right.
is related, because it all is under all of it is the behavior change. And if you have a really complex relationship with your body, you have a really complex relationship with food.
Right.
They run
Yeah.
parallel to one another. So we have to make space for that. Make space for that.
Yeah, absolutely. And I was hearing you. One of my biggest interests is trauma and how trauma shapes the way we behave. And it's really interesting. The origin of the adverse childhood event study or experiences. Sorry, adverse childhood experiences study was actually an obesity study. And so they actually had a program for weight loss, and they realized that people who were losing weight, being very successful on the study, they were dropping out and putting all the weight back again. And they interviewed this group, and they realized these people, the prevalence of sexual abuse was abuse in general, but sexual trauma was actually very high, and that was related with putting on weight. And that actually triggered the actually major adverse childhood experiences study. So I really think it's really interesting, because in my experience I find that many behaviors, and especially when you're overweight, when you have a dysfunctional relationship with food somehow, they're actually adaptative. They are protecting you from something. So they sort of make sense in a way. And if we don't really understand what's underneath it, we sort of don't understand that person, and the behavior won't stick anyway. And it won't be necessarily better for them to lose weight. So, yes, I was reminding me of that study. So I think it's so crucial what you're mentioning about, the relationship that we have with our bodies, and how that shapes behavior change, or shapes, the attitude we have towards food and weight. So I think actually this is the perfect segue, because you talk about soy recently. So I was going to ask you major myths you find in your consultations. What sort of beliefs you come across, both in cancer patients and health providers,
Mhm.
in terms of nutrition?
In terms of their relationship with meat, red meat?
We, yeah, with nutrition and foods and all of that. Yes.
So, on the cardiometabolic side, people who are coming in for weight management, diabetes, um, cardiovascular disease, they that that tends to have very high consumption of meat, or what I would say was probably more aligned with all of our data on American feeding habits and trends. And so they are eating hamburgers, hot dogs, sausages, steak, um, in, 5 to 6 times per week, in addition to poultry, and then at a much lower level, the fish. And so I think it's all very represented in what we have, the NHANES data. It's all very aligned with what we see in NHANES. When I educate about the presence of red meat in the diet, I do educate about how much saturated fat specifically is in the meat that they're consuming. And I draw some comparisons between 90-10 ground beef. What does it mean that it's 90-10? What does it mean that it's 80-20? What does it mean that I had a cut of strip steak versus a small amount of filet mignon? So I do some of that. That's kind of the basic general education that goes into, like, what am I eating? What am I actually eating? And what's driving the calories higher? And the answer is it's the amount of grams of fat that's in the cut of meat that you're eating. Is that the most damaging or dangerous thing that's in there? Depends how it's prepared. We talk about preparation method. We talk about a country fried steak. We have something here called country fried steak, which is you take a cut of steak and then you batter it and then you throw it in the frying pan. This is going to be, and then you cover it in gravy. So this is going to be extraordinarily different exposure to red meat than, say, a 3-ounce piece of filet mignon. So there is a reason why American consumption of red meat is so high. There are lots of reasons. That's a whole separate podcast, right? But I will say that for what I do in my practice, again, because I am an insurance-based provider, I accept everyone who I think it's so important for addressing the needs of your community, to meet your community where they are in terms of their ability to pay privately, or they have to use their benefits. I do have to acknowledge and honor that there might not just be a knowledge deficit. This might be the only type of meat that people have access to. This may be the only type of protein that people have access to. So I have to figure out how to educate within their budget and in a sensitive way through the lens of health equity. And how do we make those shifts? How do we make the shift from 2 hot dogs, breakfast sausage, dinner sausage, and 80-20 ground beef 5 times a week? Is the right way to do that? Well, there's an economic argument to be made for shifting to chicken. There's an economic argument to be made for shifting to frozen fish fillets. Frozen versus fresh fish, 2 totally separate price points. People are shocked when they learn that. Is there access to frozen fish at every grocery store? Pretty much. I mean, you might not have the whole variety that you have at certain, from grocery store A to grocery store B. And then what does that look like? What does that look like to create a reasonable goal for someone who's eating bacon, hot dogs, sausage, hamburgers 5 to 6 times a week, to create a reasonable goal that will shift 2 of those out? And usually that's the way I get the most compliance, is that the goals, the SMART, the R, right? Realistic,
Right.
is realistic. I think that's where things get a little complex, or this is where there's you work with people long enough, you understand where the nuance has to really live and reside. And I think that that's what's happening when I'm creating these SMART goals, is that I'm really paying very close attention to where the barriers to the change are. And I think the barriers for changing the red meat consumption, it's education and access. And so education, meaning that they don't realize that, I have lots of beautiful graphics. What is one hamburger patty in terms of calories where's the contribution of the calories coming from versus a piece of chicken breast versus white fish. And graphically, when I show people that, they're like, it starts to make a connection like, oh, I actually don't, I hate salmon, but I like cod. Great. That's great. Let's stay right there because I happen to know that at nearly every grocery store, there's some frozen cod. So let's make a smart goal that between now and the next time you see me in 2 to 3 weeks, that you will get to Acme and you will prepare one cod recipe for dinner. And then they come back and they're like, I put some olive oil and lemon on it and it wasn't bad. And I'm like, win, 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 win. And then we go from there. So it has to be, I love the SMART goal framework for nutrition. I love it, love it, love it, love it. Works so well. And it collects a win. It collects a win for them very, very early. And it's a small change because we're not in a hurry. And again, that's the other thing about these short format social media posts and clips. And it's like it feels like it's very like do it all, do it right now, and do it perfectly. And that's really some people buy right into that and then they do it and then it's not sustainable.
Right.
And then, then where are we? If we failed, then it's a failure, and that sucks, right? Nobody's to fail.
Yeah, absolutely. And yeah, that's such a key aspect. And then next time they're going to try to change, that actually has an impact. The fact that you feel that you failed before, so in terms of agency, sort of has a real impact on people. Absolutely. Um, all right, Kerry, we have been chatting for a while, and this is so interesting. And would love for you to. Uh, is there anything in the conversation that you would like to add before the end of the podcast, and anything we haven't touched on that you think is really crucial and important to bring?
Hmm. Okay, what have we not talked about? We talked about a lot. We talked a lot about
Yeah, we covered a lot, but
before.
I feel there's so many. I mean, nutrition is such a broad world, and I feel, let me just say that you would be happy in Portugal because we eat lots of cod.
Oh, I would. Yes, I like the peppers and a little tomato, little lemon juice,
Yeah,
or
so
and some
very
out. For um, I want to talk about some of the other maybe nutrition myths you hit on soy. And again, this one just will not go away.
yeah,
It will not go away. Even when I was getting last year when I went for my annual Mamosano, the tech when I was getting the Sano said we were just chitty chatty and which you're kind of not supposed to do, but like I don't know. I can't have it.
right.
And she asked what I do for a living, and I said, "Oh, I run a nutrition practice, and actually, about half, 3/4 of my practice is risk reduction and survivorship." And she said, "Oh, so you tell them to stop eating soy, right?" And I was like, "Oh my gosh, no!" And I was thinking to myself, "My goodness, this is a healthcare provider, right? This is a healthcare provider, and I'm so concerned that." She has been administering these, and maybe this has worked its way into another patient's ear before. I was so upset. I mean, she works at a breast center at a major hospital here. I was so upset, but it highlighted to me the fact that this is going to take a lot of time to put this idea to bed. That soy is, you should not, even if you have an estrogen sensitive breast cancer, you shouldn't be scared of tofu and tempeh unless you don't like it. If the texture turns you off, you get a pass.
Right.
But you shouldn't be creating another food rule
Mm.
for yourself. Um, and, soy does promote heart health as well, and we still have a fair amount of patients. We didn't talk too much about this or what else are people coming in with? What do they have going on? We talked a little about some of the long-term treatment side effects, dysphagia, changes in dentition, smell, taste, mouth sores. But I would say pretty much every survivor that I've worked with has a couple of areas where nutrition can play a critical role, either in the reversal of some other disease. Like, being on an aromatase inhibitor creates, for 5 years, creates a certain amount of side effects. And so can, not guarantee, but can. And so it's not uncommon that I'll have a breast cancer survivor who also needs a certain amount of counseling on lipid management
Right.
and bone health, or for example, bone health,
Right.
as that, suppressing the body's estrogen production, has that impacted their bone health? Was that a function of the chemotherapy that they were receiving or the radiation? So, there's other areas too. Again, this would be maybe the next nutrition podcast.
Yeah,
you know,
we have certainly, and also fatigue is one of
Mhm.
the big ones, and I think nutrition is also such an interesting. It has such an interesting role on that. Yeah, so basically, many of the side effects can be and again, it's not only they're not only solved by nutrition, but nutrition needs to be part of an integrated approach to those side effects. And it's interesting because in what concerns fatigue, which is really common, um, people still go to their doctors and they're still told there's nothing we can do regarding fatigue. And when we think about the lifestyle pillars, not only nutrition, but we have physical exercise and we have so many other things that can also be useful. So we should do an episode only on side effects and nutrition because it's such an important topic.
Is
Absolutely.
you could do a whole episode on myths, the eating organic versus conventional. Do I need to? I would say actually in the hypervigilant people, I forgot to mention that. That would be one thing that they're coming in. They're only eating organic food, and that compresses their food portfolio because for a lot of people there's a cost barrier, there's an access barrier. And so, I do always answer the question, I think in my first appointments, usually with everyone who's coming in for risk reduction or survivorship is, do you feel like you are only drawn towards organic foods? Will you not buy your blueberries if they're not organic? And the Dirty Dozen list has impacted decision making in cancer survivors, and I pull them away from that. And they say, again, let's come back to this soften the gaze approach. If you want to choose organic because you like the way it tastes and it's very accessible and it increases your consumption, then great. Stick with the organic. I have an organic market up the road. I've never tasted carrots that are more carroty than organic,
Right.
but they're quite expensive. But
Right.
so it's not appropriate. It's not appropriate. The conventionally raised foods don't drive your risk profile way off the charts. What because it can create, like I said, an access barrier. So I really do I find that one also coming back to this idea of empowerment. I do find that one empowering too, because then it's like I don't what happens is they interpret that as, "Oh, I like raspberries, but they're $9 for that little pint, and if I don't eat it, it goes bad by the time I get them out of the car." And I
Right.
still I chalk that I categorize that that conversation, that nutrition myth conversation, as being very empowering. If you want to eat organic, absolutely. But if you can't afford it or there's an access situation, it is absolutely safe and appropriate for you to incorporate conventionally raised fruits and vegetables into your diet.
Right. Thank you, Kerry. I would love you to also, if you want to leave us with some key messages, if you're a cancer survivor and you want to start implementing some changes, you're not sure where to start or how to start. Really simple tools that people could use to start their journey in health without feeling overwhelmed.
Mhm. Yeah, I so we one the f- one I think is the most straightforward questions that we know is evidence based is to ask survivors, are you choosing sugar sweetened beverages? And we actually felt strongly enough at ACLM that sugar sweetened beverages are part of the risky substance pillar. Because what we know about sugar sweetened beverages is that not necessarily that sugar fuels cancer, but
Yeah.
sugar sweetened beverages can add to body adiposity. And I think that if the easiest change we're talking about, or the easiest to implement first, is to bring awareness to that question. Are you choosing soda with added sugar? Are you choosing tons of Gatorades, those sorts of beverages? And is there an opportunity to swap those out for something that you can something that doesn't have any added sugar, something like a seltzer with a squeeze of lemon or a seltzer with a squeeze of orange or some sort of mocktail that you make that doesn't have all of this highly refined sugar that's lots of calories to the day. So while it's not necessarily the sugar that's promoting the cancer, it could potentially be crowding out an opportunity to maybe get like a little natural fruit juice from, say, a squeeze of an orange or some citrus from the squeeze of a lemon. That would be my first suggestion. Start there. My second suggestion would be thinking about processed meat, deli meat, hot dog, bacon, sausages. How much of a role are those playing in your day to day, week to week, month to month? Is it a minimal? Is it one serving a week? Is it 6 servings a week? I would start there with the awareness piece and then making some slow, conscientious shifts to chicken breast or fish. Or if you're ready for tofu because you got cleared of the knowledge that tofu causes cancer, thinking about tofu. I suggest there's a couple of cookbooks that are out on the market. I don't endorse any one of them in over the other, but I think that any cookbook that is emphasizing a whole food diet where it could be in the Mediterranean diet framework. Thinking about if you have a cookbook or you have a tool, not the internet. Leave the internet alone for this one. Thinking
Right.
about cookbook that you has nice, beautiful pictures that can give you this sense of information, the inspiration. You can flip through the pages and dog ear a couple of those whole food recipes, those beautiful pictures. The food stylists come in, they make everything look incredible. I think that's another right off the bat. What am I doing this week? I haven't gotten my appointment with a nutrition dietitianist. But what can I do right now? Those are 3 things that I would consider.
Amazing. Thank you so much, Kerry. I would really take this opportunity to thank you for coming on the podcast. I think it was such an interesting um, session and episode, and I feel we have so many hot topics coming out of this conversation as well. So thank you, and yeah, I hope we will bring you back at some stage.
Awesome. Thank you. So I'd be honored to come back. Thank you so much, Diana. This is wonderful.
Thank you. And thank you everyone for listening once again. And I'll see you next time.